as we all go down this journey, rediscovering a proper human diet and what that means to each of us individually, many of us check lab work. We check it very often. We try to figure out, is this actually improving my health or harming my health? Is this good information? Is this misinformation? Today, I have a good friend of mine back on for, I don't know how many times he's been on the channel, not enough. Dr. Robert Cywes, who's an MD, PhD, who is intimately familiar with the proper human diet and also forgot to turn off his cell phone. Dr. Cywes, welcome. Hope that's not a medical emergency.
No, it isn't. Thank you very much, Ken. I'm sorry about that. I meant to turn that off earlier, but great to see you again. As you said, we've got a long-standing history of camaraderie and support from the days where we were out in the dark backwoods and everybody was bombing at us. It hasn't changed that much, although now we tend to be more on the inside, which is just a great place to be positioned, of health policy, of changing the diet and the philosophy toward health. And I spilled coffee on my PhD shirt, so I had to wear this as a default, but I wear that shirt often and proudly.
Thank you very much for that. And I think that it's absolutely honest and accurate to say we're all searching for what is a proper human diet. What should we eat? What shouldn't we eat? Because as you know, doctor, we're the only species on planet Earth that somehow forgot what we're supposed to eat. We've been confused or perhaps misled as to what a proper human diet actually is. And then I think that the more you and I and other leaders in this field delve into this, I think we're starting to bump up against the fact that many of the lab tests that we check and many of the lab reference ranges or normal ranges are probably inaccurate for someone who's actually eating a proper human diet, as you and I would define it, versus somebody who you might colloquially say is a bread eater. The lab results, the optimal levels are perhaps different for people who eat mostly meat or all meat. What have you found in your practice that kind of echoes that?
Oh, there's no question. By the way, thank you very much. I know it's about to come up. Fabulous and really impressive, and going to be a very useful tool for a lot of people, particularly the way you positioned it. But I think, Ken, one of the things, I completely ignore the normal tables, in part because they're so broad and so wide. Where do we fit into that? And I've developed, first of all, in my own clinical practice, and I'm a clinical doctor, my own ranges that work, as you said, for a variety of people in the space that we work in. But I think there's something far more important that you and I understand as kind of old graying. I cut my beard off, it's gray completely. But as graybeards in this science, we came from an era of physiology, and we've been trapped in a furrow of epidemiology. What do I mean by that? Most doctors now are trained to look at numbers as a target to throw medication at. This number's high, this number's low. They don't ask questions of how the number got high or low. It's out of range or it's in range. Here's a number, here's a medication for you. I tend to look at blood work where the numbers are characters in an ever-changing storyline. And when I see my patients, I like to read the threads, the complex physiologic and homeostatic threads that define us as human beings. The story of inflammation, the story of insulin, the story of glucose and energy metabolism. And obviously in a ketogenic diet that changes from being sugar to being fat. We've got to be on top of that. And that storyline also tells me when to be concerned. You know, Ken, one of the interesting things is that a lot of us, even in our space, talk about diet as if it's a static thing, but it isn't. Homeostasis is a feedback thing, and it's the way the human body works. So as part of that, our diet has to be flexible and dynamic to keep pace with what's happening inside of our bodies. The diet just drives the hormonal milieu. And as such, what we want to be able to do as physicians is check that blood work to monitor and be ahead of the changes and the little tweaks that folks need to make in their diet. So for example, if you're getting rid of diabetes, an ultra low carbohydrate, a carnivore diet, maybe eating once a day with some intermittent fasting is ideal. But down the road, you can't just keep fasting. You know, when a cloud of dust walks into the room from a previously 300-pound diabetic, we know it's time to add some calories back or add some food back. So the blood work helps me to monitor and be ahead of disease, but also to understand the genetic expression of certain diseases and how we can modify that with diet. So again, feedback. We use diet to treat genetics, and we use lifestyle to modify some of the dietary stuff. So I know that's a long story, but it's a very different way of looking and reading blood work than the average physician. And you know what, the one last thing I'll say just in this monologue is that the problem with this book is you've empowered your patients to be smarter than most of their doctors.
And unfortunately, and I'm not happy about that, but unfortunately, you're exactly right. I think the days of the complacent, lazy, ill-informed doctor are quickly coming to an end. I think doctors that just kind of thoughtlessly practice algorithmic medicine is coming to an end. Those doctors I think are probably already starting to feel the pinch of very well-informed, self-educated patients pushing back and saying, wait a minute, what? And then also, I predict that in the next 3 to 5 years, these same lackadaisical physicians are going to feel the pinch of artificial intelligence, because I think it's a matter of time before either United Healthcare or Blue Cross Blue Shield or one of the insurance companies says, you know, and they did this with nurse practitioners, you probably remember. You can see the doctor for a $35 copay, but you can see a nurse practitioner for a $15 copay. And reindeer games like that, I predict within the next 3 to 5 years that they will use their lobbyists to get laws passed that make it perfectly legal for them to say, hey, you can see the AI doctor for no copay. And at that point, there will be tens of thousands of doctors looking for work, because they'll no longer have a waiting room full of patients who are disgruntled and waiting for their appointment that's an hour behind. I think there's going to be so many changes coming in medicine over the next 5 to 10 years, and I think you and I both played a small part in some of that. But I love it when patients are informed, educated, empowered. They realize that their doctor is not their daddy. Their doctor is their learned health consultant or partner, that they can take it or leave it, that they don't have to take a prescription because their doctor wrote it. I think all of those things are very good things for the liberty of the average patient. And so I'm happy to be here for it and to play a small role in it. And I know you are too.
I agree completely with you. And I think along those lines, Ken, one of the ways that I have changed my own practice, or I've really always been this guy, but I've created a practice that supports what I do. As you said, healthcare has become this algorithm dictated to us by industry. So I do feel sorry for most physicians, even thinking physicians, who are trapped in this algorithm of a slave to their employer who's imposing standard guidelines and algorithms where they want to individualize care, but they have to support best practices that certainly are maybe epidemiologic, but not physiologically based. So the way that I practice, and I think this is something that you're talking about that we're going to see, both with ChatGPT, AI, your book, what it does is it empowers patients with knowledge. So I, as a physician, can no longer be dictatorial to my patients or paternalistic. Oh, you must take a statin. If you don't, you're a terrible patient. No, let's create an environment of knowledgeable, shared decision-making. As a surgeon, my background is in surgery. Consent is a very important thing. Most doctors, particularly cardiologists prescribing statins, use compliance, which is a combination of trust me, I'm a doctor, and ignorance, and whatever you do, don't go to Google. And I think shared decision-making with knowledge, patients come with their ChatGPT knowledge, we sort through it. And I say, okay, these are the reasons to take a statin, these are the reasons not to. Let's come to a consensus about what is best for you. And if you don't agree or I don't agree, it doesn't matter. I'll support you in anything we do. So shared decision-making and individualization of care, because everybody is an individual. There are a lot of trends. And I think the other part is I educate my patients how to use AI rather than am afraid of or tell them not to use AI. AI is smarter than me. I've got it open right now. I use it all the time, and it empowers me to take care of my patients better.
Oh, I totally agree. I use ChatGPT every single day, multiple times a day. And there are a lot of people out there who are terrified of the AI, but I would encourage everybody to get familiar with it, whether it's Grok, whether it's Gemini, whether it's ChatGPT. Basically, it's like having one friend in your pocket who's about 14 years old, but they have a PhD level education in every single subject on earth. And so when I say 14 years old, the reason I say that is because sometimes it makes foolish mistakes, just like a 14-year-old would. But this is a 14-year-old with a PhD in every single topic that any university on planet Earth can give you. And so you can send this PhD off to research things for you, and it'll come back and it'll say, not only this is what I found, but here's a link to the research that I based my answer on, and you can click the link and then go, yep, that supports it, or no, he's being 14 years old. So it's definitely not perfect. But the thing people need to understand is, like, my first edition of Common Sense Labs was self-published, lots of typos, lots of errors. It took us years to update that with a second edition, right? The thing about all the AI is that it takes seconds to update it. And when you update one of them, you update all of them, and they never forget that update. They don't make mistakes like a human being would. And so that's why I think it's inevitable that any profession that practices an algorithmic kind of thing, if this, then do this, they're toast. They need to be training to be a welder or a plumber or an electrician or a surgeon, because I think probably, what do you think, another 10 or 15 years before the robots with AI completely replace the surgeons. And I want to give you just a little more credit. You said you're a surgeon by training, but you also have a PhD in, I think, physiology, if I'm not.
Liver physiology.
Liver physiology. Yeah. So you're a thinking surgeon, unlike many other surgeons out there. You actually know how to think about things. And you mentioned a couple of times epidemiological research. And there are people who will watch this who don't know about statistics or epidemiology or the different powers of research. So in epidemiological studies, when you just study a group of people, and typically, at least in nutrition, you ask them multiple choice or multiple guess questions once a year or every 5 years. Sometimes just you ask them once when the study begins. How many cups of ribs do you eat in a 3-month period? Some foolish question like that. Then you ask the same multiple choice test again 5 years later in some of the studies. And so if you know that going in, you're like, well, that's ridiculous. First of all, people are guessing, and you're calling that data. Secondly, how can you even publish any kind of meaningful conclusion based on that kind of research? That's not even real research. I think if you, well, we've seen this, like with our friend Ivor Cummings, who is, very into the physical sciences, physics and mathematics and engineering. He said nutrition research is the biggest bunch of bunk he's ever seen in his life. Like if an engineer presented that kind of research when they were building a bridge, they would be not only fired, but probably beat up behind the shed before they got put in their car and sent on their way. But the average doctor doesn't know that. They've forgotten that. And so they will make clinical decisions based on this one human sitting in front of them in the exam room, based on this epidemiological research. And it's maddening to me, because you and I have been talking about this for years. And more so, patients are coming on board and they're like, oh, I get it. That you can't make any kind of conclusion based on research like that. How in the world could you make a clinical recommendation to me based on epidemiological research? That reveals to me, doctor, that you don't even have a good grasp of the basic scientific principles of research. And you and I have made many doctors mad when an informed patient goes into the exam room and walks out, and they're smiling and the doctor's frowning, and they're not going to take that step.
I absolutely. And you know what? Unfortunately, a lot of my patients, I say, look, don't say anything. You're not going to change that doctor's perspective. They're the expert. You know what? Please go ahead and call the prescription in. The doctor is obligated to do that, to check the box, to get paid. You do not have to put it in your mouth, and they are not going to come to your home and put it in your mouth. So you decide. But I think, Ken, more importantly for me, as a physiologic physician, as somebody who follows the story of how the human body works, as new evidence, and you think, oh, we're so smart, we know everything. We don't. And new information, new evidence is continuously coming along. And one of the things that we have to be able to do is to change our minds, change our perspectives, and perhaps say, now that I know this, I was wrong about saying that. So, for example, in 1963, the Randall cycle put it out. And it was actually really cool. The Randall cycle is which way the mitochondria work in terms of using fat or protein. And they did not know about a crucial molecule called glucagon. And they postulated that, but once you know what glucagon does, it alters, it changes the whole Randall cycle. And I am here to tell you that I have been wrong about a fact that I was very emphatic about. And it's an interesting wrong that I would like to correct. And it's blood work that has led me to this conclusion, the blood work that you're talking about. And so what fact have I been wrong about? Well, it's a correct fact that is incorrect. You know that, and I've heard you say this, and I Googled you, or ChatGPT found a quote that you said that the human body makes glucose via gluconeogenesis. The human liver, and I know this very well working in the liver, provides you with all the glucose you need. So there is absolutely zero reason for you to consume sugar. And the assumption there is that the liver makes all that sugar, and it is 100% correct that you do not need to consume sugar. Even though you need blood sugar, you do not need to consume it because the liver makes it from protein, glycerol, and lactate. That is a fact. However, the fact that you do not need to consume glucose is false in humans. And that shattered my mind a little bit. And how did I come across this? Reading blood work. So my little quote that I use for blood work is, and I think you'll appreciate this. This is from me. I'll take the credit for that one. Blood work should be a symphony of data. And when the orchestra is finely tuned and led by the conductor insulin, it produces beautiful music. But when it is out of tune, it is a cacophony of noise. And what I started seeing is people who were insulin resistant, diabetic, obese, had a variety of different things, went on an ultra low carbohydrate diet. Let's call it a carnivore diet. And they massively improved their biologic metrics, their blood work. Beautiful story. The problem, just like with diets, where you're losing weight, any diet, it doesn't stop when you reach a certain point. It continues. So if you're really sick and you do these things that improve all these metrics, you lose weight, your diabetes goes away, it doesn't stop. It continues. And when that pendulum swings across to the other side, so at first you get harm from inflammation and all the problems of eating carbohydrates, whatever it may be. But then as you heal, the healing process doesn't stop. And sometimes we get into trouble where excessive healing causes harm. Excessive healing causes harm. And in this case, in the case that I'm talking about, and you've heard me talk about this a lot, and it's something I've seen because of a book like yours, is something called insulin suppression. So with insulin resistant, you produce a lot of insulin, but the cell puts up a barrier and you cannot get the sugar to go into the cell. And some people produce high amounts of insulin, like myself, so we can become obese. Other people don't, and they become diabetic, where they can't clear that sugar. If you go on a zero carbohydrate diet, carnivore diet, that improves. And it improves tremendously, and your insulin levels fall, glucagon goes up, you get into ketosis. However, the physiologic statement that you and I were trained with, the equivalent of the Randall cycle, was that as blood sugar rises, it triggers the release of insulin. And that is a false statement for the most part. The pancreas does not respond in a meaningful way to rising blood sugar. And we know this from, if you put dextrose in TPN, if you give intravenous sugar, there's a much more blunted insulin response. It rises by about 10 to 15%, but not adequately to clear the blood sugar. if your source of sugar is gluconeogenesis or intravenous sugar. So there's something else that must trigger the release of insulin. And what we've learned from guys like Ralph DeFronzo, who's a big diabetes worker, and that has become so popular over the last maybe decade, is that in humans, the primary trigger for insulin release is an intestinal hormone called GLP-1. And I'll talk about carnivore animals, how they've evolved to be different. But in humans, about 10 or 15% of GLP-1 is triggered by amino acids, protein in our diet. But 70+% of GLP-1 is triggered by a small amount of sugar in the diet. And GLP-1 does two things in the pancreas. It releases insulin and it lowers glucagon levels. It blocks glucagon or reduces glucagon. So in humans, the primary trigger in someone who's insulin sensitive of insulin release is GLP-1. And the only way to trigger GLP-1 non-pharmacologically is with a small amount of sugar in our diet. So for example,
protein doesn't do it.
Right. So let's, in a pure carnivore mammal, like a lion or a wolf, if you look at their milk, it's very, very high in protein, very low in sugar, high in fat, and 90% of their GLP-1 is released in response to amino acids. That is a pure carnivore adapted animal. In human beings, that's 10 or 15% with 70%. And Ralph DeFronzo has shown this in several papers. And he's one of the big diabetic researchers. I disagree with Ralph on a lot of things, bought and sold by pharma, but this data is accurate and verified. That we need, when we are insulin sensitive, we need a small amount of carbohydrate, not as a substrate, not as a source of energy, but as a trigger for GLP-1 that then releases insulin. And the problem, so what is this important? Because we see now carnivores rising A1C, we see rising triglycerides, which are where the liver's clearing the sugar. Is it important? Well, the Dave Feldman study, the lean mass hyperresponder study, beautiful study. I love the work that they did. Dave's obviously a very close colleague of ours. Clearly demonstrated the purpose of that study was that LDL does not cause vascular inflammation. And we know that. We started this discussion with statins. But what they did find that they didn't expect to find, that in a subset of those lean mass hyperresponder, often carnivore, ultra low carbohydrate eating folks, they started to see soft plaque that in the study was equivalent to the amount of soft plaque increase in folks on the standard American diet. So you've got people who are insulin resistant who have a certain amount of soft plaque. We expect that on CAC score, CTA, but we've got another subset of people that are supposed to be the healthiest they can possibly be, who are also forming soft plaque. How is that possible? And in my practice, I manage a large number of those patients. And they all, when they start getting soft plaque on a carnivore diet, all have very low insulin, low C-peptide, rising A1C, rising triglycerides, rising BUN. They cannot clear the gluconeogenic sugar, the sugar that their liver is making, because they don't have enough insulin to get into their muscles. It's hanging around in the bloodstream, causing vascular inflammation. When you then add a tiny amount of carbohydrate, and this is where you and I will have a little bit of a difference, the easiest way if you want to stay carnivore is in milk. There's glucose and galactose in milk, or maybe a banana or a little bit of carbohydrate, preferably low glycemic index. You fix the problem over time. And I've demonstrated that over and over in my practice. But here, the last thing I'll tell you is, before I did that, the failed experiment for me was I said, okay, Tim Noakes, who was my physiology professor, told me that rising blood sugar triggers insulin. And we know that gluconeogenesis rises blood sugar. So let's put these people on a lean protein diet, a protein-spared modified fasting, the Maria Emmerich high protein diet. And they all produced massive amounts of sugar from their protein with gluconeogenesis, high BUN, which is a measure of that breakdown. They were miserably hungry because they couldn't feed their cells because the sugar was in their bloodstream. It wasn't getting to their cells. They kept on eating more, and the numbers got worse, not better. And when we measured their insulin was super low, glucagon through the roof.
What's your definition of low insulin or super low insulin?
Well, as I'll give you the numbers, but it is a continuum. It's a storyline. But typically, an insulin of around 0.6 to 0.8 up to 1, and this is protracted fasting insulin with an insulin level in the sub 4 range, 2 point something, 2.8, 2.9. I had a patient today who was 2.8, but also simultaneously either rising triglycerides or rising blood sugar. Because not everybody's diabetogenic. So some folks have higher triglycerides with normal blood sugar. They're obesogenic. Their liver, and by the way, the liver does not require insulin to turn sugar into fat. So the liver protects you. Fat people like myself, the liver protects by turning sugar into fat. We gain weight, but our blood sugars are normal. When the liver is not able to do that effectively, that's when you see the blood sugar rise. That's the subset that gets the soft plaque. And you can correct that by triggering GLP-1. Now, there's two ways to trigger GLP-1, with sugar or with Ozempic. And there are a subset of patients, not necessarily these lean mass, so they're too light for Ozempic, but you certainly can correct it with microdosing. And that's a popular word, of GLP-1. I've stayed away from that in that population because why would I treat a super healthy person who's just swung the pendulum too far with a drug? I can help them to bring that back together. But it doesn't fix in a week or two. Just like you don't fix insulin resistance completely in a week or two, it takes months for that regulation to happen. It does take a few months. The metrics get worse before they get better, but over and over and over, we've done that analysis. So the point is that the biology is dynamic, and a static diet does not always favor a dynamic homeostatic principle. And the ultimate example of this is Paul Saladino. And Paul, 2020, fastidious carnivore, saw his testosterone going down, saw his thyroid going down, saw his muscle wasting, saw all the effects of hyperinsulinemia, low levels of insulin. Started consuming carbohydrates and started to see an improvement. Now, the problem with Paul is, in my opinion, he's gone the other way. He's 300-400 grams of carbohydrates. And the other issue, the final issue with someone like Paul is I get a lot of patients who come in, new patients, oh, I'm diabetic, I've been following the Saladino diet, but I'm getting worse. Well, of course, you're insulin resistant and eating Saladino-type carbohydrates. Not good, not bueno, as you would say. Let's get you to become insulin sensitive by getting rid of the carbohydrates. Then we'll do the Ken Berry lab work, track and monitor where you are, and intervene progressively as appropriate. And that's the dynamic stuff that I bring to the table as a clinician.
What percentage of patients or clients have you seen that it kind of express this physiology of let's just say of everyone who was obese and pre-diabetic or type 2 diabetic, they go on either ketovore or carnivore, very, very low carb, almost exclusively meat, and maybe less than 10 total grams of carbohydrates a day. What percentage of people, because they're all going to reverse their type 2 diabetes, but then I see a subset of people, and it's almost exclusively carnivores, who their A1C will start to creep up again after they achieve normal. It'll get to 5.7, 5.8, maybe 5.9. That's about as high as I ever see it go. And then their triglycerides are still perfect. Their HDL is perfect. And then if you check a fructosamine test on them, which gives you roughly a 2 to 3 week window of looking at how much their albumin is being glycated, it's almost without exception just perfectly normal. But that A1C is creeping up. And you've probably heard Professor Ben Bickman and I talk about this before, and then several other doctors in this space. Our current hypothesis is that because of the nutrient density and the healthiness of this diet, that their red blood cells, instead of living on average 110 days, which is the kind of average, that their red blood cells are living 120, 130 days maybe, and giving that red blood cell more time to glycate. Because if in fact they were becoming pre-diabetic again, the fructosamine you would expect, which is in many cases a more accurate test, it's less foolable than a hemoglobin A1C, the fructosamine would be creeping up as well, but we see it stay normal, but their A1C is creeping up. And I have not seen the elevation in triglycerides that you were speaking of earlier. I definitely want to hear more about that. So what percentage of patients would you say, do you think it's a subset, or do you think this happens to everyone if they use carnivore to reverse their type 2 diabetes and their obesity? Does everyone fit this criteria and eventually need to add some kind of simple carbohydrates, non-inflammatory carbohydrates back in? Or is it everyone, or is it just a percentage of those people?
A very good question. And so let me rephrase the subset of people that we're looking at. Okay, there are a lot of people like myself who are carnivore based. That we're 95% carnivore, but we eat some things that are not carnivore. It's less likely to happen to that group. So what we're looking at is the group that does not eat food that contains carbohydrates, period. So let's talk about the pure carnivores, but there are some who are ultra low carb or maybe eating one meal a day and got protracted periods of fasting. That's the group I'm talking about. Now, within that group, I will tell you that 100% of them, or pretty close to 100% of them, over time, and that may be 18 months like Saladino, typically 3 to 5 years of doing this, are going to begin to see changes. And there are two pathways. Obviously, it's a bell curve, but there are two pathways, and that's why you may not have seen it exactly. In some folks, like you said, their triglycerides don't go up, but you start to see a slight rise in that A1C. Ideally, these folks should have the lowest A1C, but you start to see a rise in A1C, but you also do see a slight rise in BUN. BUN is the conversion, it's a kidney number, but I look at that as a conversion of protein to sugar. It's the breakdown product. We might see a slight rise in uric acid. Creatinine usually stays fairly low. And we also see a very, very high glucagon because that's driving the gluconeogenesis. And then we can look at insulin and C-peptide and see those levels drop. Those folks, what defines them then is not a massive diabetic-like rise in blood glucose, but they may say my dawn effect used to be 90, 95, now it's 110, 115, and it stays up for a little bit longer. Almost, we're so clouded by seeing bad sugars in everybody that we're not able to see that nuance. 10 points, 10-point elevation in blood sugar, and they'll wear their CGMs, you'll see a 110, 105, so you see an average blood sugar right around 100, whereas before they were in the 70s and 80s. And then clinically, they feel flat, they feel fatigued, they can't work out as much. So I also look at free and total testosterone, and we see a reduction, because insulin regulates that through aromatase activity, and we see a decrease in testosterone in men or a slight increase in females. So there's a lot of nuance factors. We often see also thyroid numbers going off, and actually Saladino saw that quite a bit with himself. We see the T3 numbers. My range for T3 is 2.7 to 3.334. We start to see it go down to 2.4, 2.3. All the numbers are okay. TSH is okay, but we just see those numbers come down. Those people have the slight elevation in sugar, and then you get a CAC score or a CT angio, which shows the soft plaque, and now that soft plaque is positive. Why is it positive? The other population that has equal insulin suppression, but is the population that can clear sugar fairly well in their liver, because the liver doesn't require insulin. So those are the folks who you start to see fairly normal A1C, or maybe the A1C used to be 4.9, now it's 5.3 or 5.4, but their triglycerides used to be in the 50s with an HDL of 100. The HDL comes down now, it's still 75, 78. My marker is 75 and above, but their triglycerides are now 80, 90, 100. Not horrible by any means, but by my means, I use 75, 75, creeping up. And those folks are not going to get the cardiovascular damage. But the damage that comes from those folks is going to be your risk of Alzheimer's. We see an increase in autoimmune disease. We see a increased risk in cancer down the road. They may also start having, and this is something that we should talk about as well at some point, but we start to see electrical problems with their heart. We start to see arrhythmias. We start to see potentially atrial fibrillation or bradycardia in some of our athletes. Saw a patient the other day who had a supremely fit guy, ran Boston in a sub 230, young guy in his late 30s with 15-second pauses. So it's a Mobitz 2 type block. And this was one of the consequences of that electrical problem. So it's not just the plumbing, the rising CAC score. And it's subtle, but I start with the symptoms. and the inquisitiveness to look at these folks' blood work. And glucagon is also one of the telling markers. So it is a storyline. But I would venture, and again, I know that for the third time in my life, my facts are going to clash with deeply held evangelical beliefs of certain people. But I see this every day, and it is eminently easy to manage if you explain it well to those folks. And they're also thankful when they start to feel better because they're eating a little bit of carbohydrate. One final piece of information, Tim Noakes, a guy called Prince, but with Tim Noakes, published a paper in January of this year looking at endurance athletes who are on an ultra low carbohydrate diet and was introducing 15 to 30 grams of carbohydrate, slow carbohydrates. They don't spike insulin that raise it, like a banana or something like that, before a workout to raise insulin to allow the sugar to go into the muscles, but not enough to block lipolysis or fat mobilization and ketogenesis. And those athletes performed the best during endurance and also recovered the best. And it's a paper by Prince earlier this year. So there's evidence in the literature, but the Feldman paper was the key thing for me. And it's all subtle. But that's why and we talked about this earlier, my narrow range of ideal numbers are far more narrow than the standard reference ranges. If your insulin goes from 2 to 24, you're never going to pick up insulin disruptions.
Absolutely.
So that's the explanation. But again, it's individualized by the patient and by the symptoms.
Yeah, and just to kind of expand on what Dr. Cywes just said, LabCorp considers a fasting insulin level of 24.9 to be normal. And they consider a C-peptide of 4.4 to be normal. And then you'll love this. I thought this was right, but I verified it right before. Their normal range for fructosamine is 0 to 285. Now, you would be dead if your fructosamine level was 0. You would not be able to sustain human life. So then they go on to say, well, really, for non-diabetics, it's 205 to 285. But their reference range is 0 to 285. And so I totally agree with you that many of the reference intervals are far too broad. I totally agree with that. Now, let's get back to I missed it. So you're saying that there's a subset, a certain percentage of patients who start to get this lowering of the T3, lowering of the testosterone, or are you saying that will eventually happen to anyone if they're strict enough carnivore for long enough?
Yeah, if you are so ketogenic that you remain in ketosis 24/7, and you really have very little need or very little trigger of insulin, that insulin suppression, those low numbers with the falling off of some of the other numbers, either toward the obesogenic side where the liver is making a lot of triglycerides, or the rising blood sugar, which is genetically predetermined. Some people's livers are very good at turning sugar into fat, others are not. And that is insulin independent. So that defines those that are going to have the rising CAC score versus those that are going to get damage from the lack of insulin. And insulin is if you look up, all you got is ChatGPT. I'm going to be speaking on this on Saturday at a conference in San Diego. But if you look at the myriad functions of insulin, there are so many. In the brain, in the vascular system, it controls nitric oxide. It controls energy delivery to the brain and cellular. So Alzheimer's, it's an important thing. So obviously, everybody knows what the effects of insulin resistance are. I think you've got to be hiding under a rock in 2025 to not know, and there are a lot of people still hiding under rocks, to not know the effects of insulin resistance. But the effects of insulin suppression are almost parallel, but with some differences. In the insulin resistance, your glucagon is low until it rises paradoxically. But with insulin sensitivity, it's usually high. HDL is usually high, but triglycerides are rising. So, and also the other thing that regulates insulin, and this is something that Nick Norwitz did something about, or gave a little spoof talk on. One of the clues that alerts me, one of the first clues that alerts me to insulin suppression is super high LDL and cholesterol. Now, get this, Ken. My normal range for cholesterol is 200 to 500. every statin pusher wants that well below 200. So where the low end of my normal range is the high end of theirs. My normal range for LDL is 120 to 300. They want it below 55, I see, is the new thing. Okay? You talk about fructosamine being 0. So I'll often see patients with a cholesterol greater than 500 and an unmeasurable LDL, because it's a calculated number, or an LDL above 300. Those are two of my first clues that this may be insulin suppression, because insulin regulates cholesterol production and paradoxically cholesterol absorption from the gut. So when insulin levels are sensitive and triggered, you send HMG-CoA reductase down the cholesterol production pathway. When insulin goes down and glucagon goes up, exactly the same pathway produces ketones. So what happens to these lean mass hyperresponders, they've got low insulin, they've got high glucagon, they're continuously producing ketones, but their liver is not producing a huge amount of LDL. That's why their VLDL is low. However, insulin also regulates the packaging and the uptake of fat and chylomicrons, including cholesterol. So when your insulin is low, your insulin fails to block chylomicrons, which are the transport vehicle of fat from the gut, fat that you've eaten. So the majority of the lipid or the cholesterol in a lean mass hyperresponder with low insulin is coming from their diet, and they're all eating a high amount of fat, or the majority of them are coming from their diet, not production in the liver. And Dom D'Agostino, who I certainly love and have tremendous respect for, Dom and I were on a panel a little bit ago, and we were talking about some of these subjects, and Dom said, I take some ezetimibe. Ezetimibe is a cholesterol absorption blocking drug for those in your audience. So it's a medication very popular with a cardiologist to lower cholesterol absorption from the gut. Doesn't work on the liver, blocks absorption. And Dom said, I'm on my carnivore diet, high-fat carnivore diet. I've got a history of high cholesterol, and I started to get some xanthelasma, which is the deposition of cholesterol in and around the eyelids. And he said, because of that, when I measured my cholesterol, they were very high. So I decided to take low-dose ezetimibe. This was said on a public stage, and we discussed it. Well, that for me is pathognomonic or demonstrative of insulin suppression. And one of the ways to counter that, you can take the medication, or you can lower your cholesterol. And Nick Norwitz did a little spoof publication or poof video on this, where he said, eat Oreo cookies to lower your LDL. What you're doing is you're triggering insulin with the Oreo cookies, triggering GLP-1, which then triggers insulin. Now, the only group where we don't see this are two groups: type 1 diabetics. So I've got a lot of pure carnivore type 1 diabetics I had a 12-year-old kid in Germany last week, A1C 4.5, pure carnivore. This guy's just doing so well, but they don't need carbohydrate in their diet because they're giving themselves insulin. So they cannot get insulin suppressed. And this poor kid is diluting his insulin because he's so sensitive, he's microdosing. If you gave him that standard reference range of 24 units of insulin, he'd be dead of hypoglycemia in 5 minutes.
Absolutely.
But that's your normal range. And then the other group are the patients on GLP-1 agonists, Mounjaros, Ozempics, that kind of thing. So they don't experience that. And in fact, when I look at someone and I say, why the heck is this person's insulin high? They're insulin sensitive. And I say, what medication are you on? It always comes out that they've been backdooring some GLP-1 because it rises your insulin and drops your glucagon slightly. So by looking at the lab work, I can tell those stories and ask the right questions. A lot of these folks are giving themselves testosterone exogenously, by the way.
Gotcha. So you mentioned xanthelasma, and I've been following people on very high fat keto diets for many years, patients and people online, and then ketovore diets and carnivore diets, in some cases very high fat. And I have seen maybe 3 people out of 10,000 develop xanthomas or xanthelasmas. It's super, super rare. So I don't see that it's far less than 1%.
I'll tell you, Ken,
1%.
That is so my question. Well, let me stop you for a second, because I hear what you're saying, but it's a little bit more common in our patients when you look for it. And the two things we see is mild arcus, which is the little white ring around the iris of the eye. But a lot of people just think, oh, that's old age, or it's aging, or they ascribe
Well,
it to other
be.
things.
It's called arcus senilis,
Arcus
and it can
senilis, but
absolutely
arcus
be.
juvenalis.
How do you differentiate between arcus senilis and then arcus caused by?
Well, you really can't. But in folks who haven't had it, and now I've got a 60-year-old patient who's had a heart attack, or a 70-year-old guy who's had a stroke. They go pure carnivore. 18 months, 2 years later, they're starting to develop this, and it's not a cataract. So that's an association. I can't prove it, but certainly when, for example, the xanthomas that you and I know, it's under the eyelid on the. But I saw a patient just yesterday, I think, who had a little xanthoma right here, and I would not have said it was a xanthoma looking at him, but his ophthalmologist referred him to me because he diagnosed the xanthoma, and it's macrophages in the skin that hold on to that cholesterol. So I think it is, you're right, it's rare, but it's not as rare as it is unrecognized in mild cases. So, and not everybody develops it, but I think those are just some of the examples that we're seeing. And, you know,
so that falls under the umbrella of what you're calling insulin suppression, that's one of the symptoms. So you're saying that some people might develop xanthomas, other people might develop higher triglycerides, other people might develop lower T3, others might develop lower testosterone, but you're not seeing all these things happen in all these people, like it's manifesting with different signs and symptoms. Is that what you're saying?
Exactly right. It's a spectrum of issues, all predicated by a lack of insulin release by the pancreas. And, you know, one of the other things about the muscles is they're just so fascinating, is that the muscles at rest, you up-recruit and use a GLUT1 receptor that doesn't require insulin for just a little bit of sugar trickling in. But when you use your muscles, so the exercise folks actually benefit or demonstrate insulin suppression more readily, because what they're doing is when you exercise, even if you're very ketogenic, you need GLUT4 receptors, which are the insulin receptors. And if you don't have insulin, your GLUT4 receptors are up, but you don't have adequate insulin. Those are the guys that, like Saladino. I mean, Saladino is a massive athlete by saying this himself. And again, I'm non-judgmental about this. I think one of the key things, Ken, is that I didn't want to see this. I'm carnivore myself. I'm raising a 4 or 5-year-old next week, 95% carnivore. I'm evangelical about the carnivore diet, but as a scientist, I also cannot be so locked into my dietary evangelism that I've got the cognitive dissonance of the facts. And not only have I seen the problem, I've also corrected it in many patients.
Yes,
so
and let me just interject here, Doc, and say something for the listening audience. When we look at a lab result, like Dr. Cywes or myself, that is a proxy marker. That doesn't necessarily mean that molecule that we're looking at, whether it's insulin or C-peptide, it doesn't mean that that's the cause. And that's where a lot of doctors go astray. And a lot of people who listen to me and Dr. Cywes and others run our mouth, they'll take a side and say, no, that means this. And we have to be very clear about this, Dr. Cywes. I think you'll agree. These are all proxy markers, and they might mean what we think they mean, or they might just be kind of the molecular manifestation of something that's happening at the mitochondrial level that we literally don't have a test to measure, at least yet. It could be something that's happening in the cytosome or in the cytochrome, or it could be in the cell membrane. It could be any number of things that's manifesting as this insulin level or this T3 level. And so really it's kind of maddening when you really think about it, the amount of stuff about human physiology that we don't know. And I think probably the thing that would really tip us over into the bucket of insanity is if we were able to know all the things that we think we know, that's just not exactly what's going on at all. That's just how we see it with our semi-educated eyes. So let's see okay, let's take it. Let's do it this way, doctor. Let's take it just a person. This guy's got type 2 diabetes, and his triglycerides are 400, and his A1C is 12, and he's 200 pounds overweight. And he sees one of my videos about carnivore, or he sees one of your videos about carnivore, and he's like, this guy's a truck driver. He doesn't exercise. He's on the road 18 hours a day, or however many hours a day is legal. I think it's 14. He can't exercise. He's exhausted when he's done driving for the day, right? And he's like, okay, well, I can get meat at the truck stop. I can boil 3 dozen eggs because I'm going to be away from home for 10 days. And so he just starts living on beef, butter, bacon, and eggs. And his weight plummets. His triglycerides plummet. His A1C plummets. Everything's moving back to normal, right? You agree with that so far?
I agree completely. That is and by the way, I'll tell you, the diet of choice for that person,
yes,
if they are capable of doing it as humans, and some people are, some people aren't, is a pure high-fat carnivore diet.
I agree. I totally agree.
Long
periods this guy keeps making progress. Now, let's say 9 months later, he's lost 180 pounds. He's 20 pounds from his goal weight. His A1C is 5.4. Triglycerides are 65. HDL's up to 85, right? This guy's healthier than he's been in decades. Feels amazing. Now, his A1C, he's still eating carnivore because he loves it. He's like, I'm a meat eater, man. I can do this forever. So his A1C starts to creep up back to 5.6, 5.7, up to 5.8. And he gets a CGM and starts wearing it. And he's kind of averaging like 110, 115. But when he checks his A1C, it's still like 5.7, 5.8. It's not terrible, but it's technically pre-diabetic levels. His triglycerides stay great. What would now let's say he doesn't feel great, right? Now he starts.
There's the answer. That was what I was waiting for you to tell me.
Never ignore a patient's symptoms. Ever.
I was waiting for you to say that.
If you ignore symptoms, I totally agree. So he gets his full thyroid panel, like I talk about in Common Sense Labs, and his T3 is a little lower than he. It's like technically low, but everything else is normal. And I want to ask you about the TSH feedback loop on that in a second, if I can.
Yeah, that's interesting because sometimes you see the TSH go up before the T3 even drops.
Right. And so he's just doesn't have as much energy as he feels like he should. He gets his testosterone checked, and he'd never checked it before, so he doesn't know what it used to be. But it's 450. And let's just say that. And so what would you, if he came to you and said, look, I've been following Barry's crazy carnivore diet, and I got all these improvements, but now I'm not feeling great. I'm fatigued. My T3 seems a little low. My fasting, my blood sugar seems to be running a little higher than I would expect, and my A1C is creeping up. What should I do, Dr. Cywes? What would you tell that guy to do?
Yeah. So the first thing is we've got to recognize with the complex that you've just said, to my mind, that is entering the pendulum has swung a little beyond insulin sensitivity, which is the holy grail. And he's just swung that pendulum a little. He's overhealed, is what I call that. He's healed. He's been too good. Okay. So then very next thing I've got to tell him, you're a crackhead. There is no way on God's earth we can introduce, and this is personal to me because this is me. There's no way on God's earth I can ask you to introduce carbohydrates into your diet and control them. That's like asking an alcoholic that is too sober to have one beer. Okay.
Right.
No.
And you know, doctor, there are a lot of doctors and people who follow me and you who would have a problem with the statement that this alcoholic is too sober. And then I think some people would have a problem with your statement that this guy has healed too much. So let's stick to this guy that we're talking about here. What would you recommend to him? Because he's a sugar addict, just like me and you. He's a sugar addict, right?
Right.
And so you can't tell him start adding back in a little sugar or some carbs, or he's going to fall off. He's going to fall off the wagon. He'll be back eating the junk again, and his A1C will be rising for real.
Correct. And as a carb addict myself, I have to take that into consideration. So, and this is where you and I'm very gung-ho on this. You have some skepticism about this. But the first thing I would start to introduce, especially if his weight lost all of his weight, and if he's still overweight, there are a couple of other options. But if he's at a good weight, and when I mean overhealed, what we're trying to do is get his insulin level down. but then it goes too low. That's overhealing. So when it crosses that threshold, and you can show a graphic of that. I would introduce.
Let me interrupt
yes.
1 second. What number would you see on an insulin test and say that's too low? What's your cutoff?
Certainly, if I get suspicious at 3.5 in someone like that, but if it's below 3, that's at fasting insulin. That's where I start saying. But here's the key thing, right? But here's the key thing, Ken. It's below 3 with a blood sugar. If he's 2.9 and his blood sugar is 68, not an issue. That's sensitive. But if he's 2.9, his blood sugar is 101. That amount of insulin is not capable of controlling his blood sugar. It's a broken system again the other way. So that's almost like a type 1 diabetic. And we know that the insulin suppression looks like a Kraft 5 on the oral glucose tolerance test, which is what we use to diagnose type 1 diabetes, except the difference is those guys' blood sugar is a little bit lower. The type 1 has low insulin, but a very high blood sugar. But I will use a Kraft from time to time to look at that. But how would I treat him? I would want to find a source of carbohydrates that are not, that do not induce or trigger the addiction. And probably one of the best ones are carbohydrates that are mixed with fat, and they don't occur naturally in many places. The first one is dairy. And the problem in this country, I can buy marijuana, I can buy nicotine, I can buy alcohol, but I can't buy pasteurized full cream milk or raw milk. That is ridiculous. So that's my little pet peeve. I've just come back from South Africa. I drank pasteurized and non-pasteurized full cream milk. I didn't drink it that much because I don't trust myself. But introducing a small amount of milk, high fat, which doesn't trigger that addiction, maybe some cheese, that has a bit of carbohydrate, and then things like avocado. The average avocado is about 12 grams of carbohydrate, but it's also got some fat to it. And most people don't start carnivore. Some people do, but that's jumping into the deep end before you can swim. A lot of people have come through the ketogenic pathway and end up at carnivore. So for them, it's not a big leap to go back to some vegetables. They don't have a lot of inflammatory bowel disease, that kind of thing. Maybe some slightly starchy vegetables. Never, ever, ever grain products, and not rice or potatoes or fruit. Stay away from your name, the berries.
And just because of the addictive potential, is that why you say that?
Ken, if there are blueberries in my fridge, I'm doing drive-bys.
Sure.
Okay,
Yeah,
it's just I just don't trust myself. So, but there are sources of carbohydrate where you can get them in, and this is why I individualize. What are you capable of doing, and have boundaries around it, so that if you see yourself going sideways, we need to correct that. And it takes time. It gets worse before it gets better. Because
how does it get worse?
Right. So you've got part of this is GLP-1 suppression, and so, for example, if you never drink milk, the enzyme lactase goes down. You don't have it. So when you drink milk, you feel terrible because the milk is destroying your stomach because you don't have lactase. It takes a few weeks or months to recruit that enzyme. Exactly the same as GLP-1. And the GLP-1 at the top of the intestine is triggered by sugar. The GLP-1 at the bottom of the intestine is triggered by fat. That's where satiety comes from. I mean, the science of this is just so beautiful, elegant. But you need to recruit that GLP-1. And we haven't even yet talked about GLP-1 resistance, which is a new phenomenon that is going to become more prevalent, but it's as important as insulin resistance. But you've got to recruit those GLP-1 receptors. So at first, when you eat carbohydrates, you get a rush of sugar into your bloodstream, no insulin, so you get a little bit worse. So I always tell my patients, you're going to get a little worse before you get better. Exactly the same way when I'm treating a type 1 diabetic whose blood sugars are 160 and they're underdosed on insulin, when I increase their insulin, they all become fat, they all gain weight. So, you've got to understand those shifts are important. So I tell them, look, your blood sugar is going to go up. Don't worry about it for a little while. We're going to use a very small amount and slowly increase it. Now, one other piece of evidence, there is an incredible study, probably in my mind, one of the best peer-reported articles out there, by a woman by the name of Isabella Cooper. Did a PhD in Oxford. Isabella's one of the young bucks. She and Norwitz worked at Oxford, but Isabella did a beautiful study where she looked at a group of women who were all keto adapted. So she went to the board. She said, I'm doing my PhD. I want to put people on a ketogenic diet to see if I could get rid of diabetes. You're mad, you're crazy, it's unethical, you're going to kill them. So she said, okay, I didn't get approval for that, but then let's take people on this terrible ketogenic diet, horrible, awful diet that are fat adapted in ketosis, and put them on the standard UK diet, 267 grams of carbohydrates for 30 days, and then put them back on their diet. That's the paper. But what was interesting, when you analyze those women, every one of them was consuming between 8 and 12% of their calories as carbohydrates, which equated to around 50 to 75%. They were all in ketosis all the time. She gives the beta hydroxybutyrate level at 0.5 to 2.5. So they were fat adapted. They were on zero medication, zero supplements, because they were using a little bit of carbohydrate to trigger GLP-1. Some of them used a sweet potato. Some of them used some dairy. Some of them used carrots, beans, peas, that type of thing. There were a few berry eaters. She didn't dictate that. But that group of women is about as metabolically healthy long-term. Some of them have been doing that for 20 years. And we're in ideal shape, all with low A1Cs, beautiful paper. So if I'm going to treat this truck driver of yours, number one, I would be cautious about how I introduce them and work with him in an individual basis to say, okay, what can you have? And limit your access to it. So instead of buying this much milk, you maybe buy a little quart each time you're in your truck. The other comment that you made, which is a cool comment, and I make this all the time, having been there, it is a terrible idea for fat people to exercise. We feel miserable. So now that he's lost his weight, he can start having that as an outlet. He can start, as we escape from the prison of our own fat, we're imprisoned in our own bodies, being there. We're capable of doing more, but we have to choose to do it. And so if I can expand his emotional off-ramps, introduce physical activity psychologically and physiologically, he's less likely to get into trouble.
And would you tell him a specific number of carbohydrates to start with a day, or would you titrate that based on lab results? Is he gonna think of the carbohydrate intake almost as a prescription? He needs to eat this many carbohydrates from now on. How many would you start him on? How many carbs a day?
It's a recruitment process, as I said. So you've got very little GLP-1, you've got to recruit that. So we start with a small amount, 4 to 6 ounces. Maybe instead of putting cream in your coffee, you put some whole milk in your coffee, just a little bit. This took months, if not years, to evolve to this point. It's not going to get better suddenly. We can slowly make those changes. So just like a standard American diet person may slowly do some IF, intermittent fasting, may do some ketogenic work, end up at carnivore, same way. But eventually, depending on the size of the person and depending on the exercise level, it should be probably between 50 and 75 grams per day, ideally early in your eating window, so that you're mostly pure carnivore at the end, because you want insulin to drop early on when you're out of the store. The window that I call the eating window, I call the storage phase, dominated by insulin, human growth hormone, low human growth hormone, testosterone, and thyroid hormone. But once you've stored your food, you want glucagon to rise, insulin to fall. And as they cross over, that falling insulin gets rid of the sugar that the glucagon releases from the liver, because it'll always do that, no matter what your diet is. There's always glycogen deposition in the liver under insulin during storage. And then you empty your liver, glucagon rises further if you don't eat, insulin falls low, now you're in ketosis, now you're releasing fat. So we want to restore that 3-phase cycle each day for that truck driver so that he can come back to the middle but not cross over. The insulin resistant person is always in storage mode. The fat adapted, non-carbohydrate carnivore is almost always in fat utilization mode. And we want to get them to go through storage, glucose utilization, and then spend a long time in fat utilization, because it's fat utilization where autophagy, cellular repair, cancer surveillance, all of those things happen over there. And restoring that 3-phase homeostatic cycle is the holy grail of a diet, but we do it in phases to get there.
Gotcha. And what insulin level would you be? What's your goal insulin level to get him up to so that you think he would no longer have insulin suppression?
Somewhere between 4 and 6, fasting insulin after in that fat utilization phase, and we can measure that. You want lower triglycerides, higher HDL. HDL gets produced when you're in fat utilization. And by the way, those folks that are insulin suppressed never completely clear the sugar from their bloodstream, so their liver is always playing catch up, even in the utilization phase. And again, it's fairly complex, but I can look at those numbers and look at it and tell you where you are. But ideally, about 4 to 6 with a normal or low blood sugar. That's the key. And even if they dip super low, they're going to have ketones as well. So the other part is I don't measure ketones a lot, but I'd like to see some ketones positive, especially in that fat utilization. And I'd like to see the BUN in around the 16 to 18 range when they're fasted.
And okay, that would be your treatment plan for that guy. What about the carnivore whose A1C stays at 5.3 and their insulin is 2.4? They feel amazing. They've got tons of energy. They don't have any symptoms at all. They feel amazing, and they've been carnivore for 3 years, 5 years, 10 years or longer. Can they safely ignore this advice? Are you saying that only if somebody starts to develop these symptoms, and then you would check the blood work and you would find the possible T3, possible triglycerides, possible testosterone issues? But if they feel amazing, then they could just continue as close to zero carb as they possibly can.
Right. So I've got a little statement: is that a fine-tuned car doesn't make a lot of noise. Okay. And a fine-tuned human body does not require a lot of hormonal flux. It's more like a vibration, but it should fluctuate slightly through the day. If your body's doing this hormonally every day, that's not very healthy. That's like standing next to that car that's going brum, 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 brum. That's not necessarily a fine-tuned car. The guy that's just standing there at the light and then takes off, me and my Tesla. So what you're describing, the person that feels great, where all those hormones are at the lowest level, but again, the feedback, and we can talk about thyroid, a few others, that person is insulin sensitive. They are hormonally ideal. At some point, they may go the other way. So my advice to someone like that, especially if they're lean mass, they've got low weight, I would slightly expand their eating window. So that instead of being OMAD or eating in a 4 to 6 hour window, you maybe expand their consumption to about an 8 to 10 hour window. So they still go through the 3 phases, but they're not getting into the 4th phase. And the 4th phase is problematic, which is called the starvation phase. And the starvation phase, we see it a lot with people on Ozempic, is where you go through the first 3 phases, but you don't have adequate access to enough fat. You're a lean mass hyperresponder person. And it's not about fat. It's not about ketones. The human body is continuously cycling and rebuilding and repurposing and breaking down protein. And if you don't consume that protein, even if you're carnivore, you're getting a big protein load, but 18, 20 hours later, you're now breaking down your own muscles as a source of protein. And that's problematic. That's starvation phase. So with those carnivores, even though they may be insulin sensitive, I'm going to expand the eating window, maybe put a 2nd or a 3rd meal in there. Or so maybe that's when they have their glass of milk. Yeah.
You see muscle degradation very often in carnivores? Because
not often, but I see a lack of muscle building. I'm working out like crazy. Why am I not building muscle? And then they're taking creatine, they're taking a few supplements, but typically I'll see that muscle wasting. I don't do DEXA scans very often, but I'll see that decline. And particularly in the OMADs who are going a protracted period of time, or people who are still using extended fasts regularly. I mean, extended fast every now and then, you've got metabolic flexibility, not an issue. But if you're doing a lot of extended fasting, you're getting, and again, we can measure it, you're getting into that starvation phase. And the number that I look at there is creatinine starts to rise. And if they're not taking creatine, obviously I always tell my patients, please tell me if you're taking creatine, because like, oh my God, you're in kidney failure. No, I'm taking my creatine, because your creatinine will go up on creatine. But those are markers for me of that 4th phase, which is the starvation phase. And we do see that. So these are the nuances of clinical practice where very few people get into that, but there are a subset that do. And they feel off as well. So that's where you may introduce a third meal, extend their eating window. Because remember, the healthiest person is one who ebbs and flows throughout the day. They consume their food, they store it, they spend it, they're back to baseline, and they eat again. We human beings eat way too often. We human beings
totally agree with that. Yeah, and if you're a student of history and archaeology at all, you find out very quickly that even before the 1600s, you were considered a sinful glutton if you ate more than twice a day. And it was very, very common in many cultures to eat just one meal a day for your entire life. It was frowned upon if you did otherwise. And so you're saying that there's a subset of people for whom eating once a day or even twice a day in a kind of restricted feasting window, that's a problem?
It's a problem because their consumption is less than the utilization. And again, just like anything, you can't keep using more than you put in. You know, it's like the person with a bank account. If you've got a big bank account, you can keep spending. But at some point, if your spending outweighs your savings, that becomes a problem. And I don't like that calorie model because that's the calories in, calories out model. I don't go down that pathway. But it's not only true for macros, it's actually true also for micronutrients. And we again see people stop because the body will prioritize the single greatest priority for the human body is cellular energy provision. Without that, you're dead. So the entire focus of the human body, whether it's the brain regulating your physical activity by the central governor theory, the brain will shut your muscles down before they run out of energy because the brain senses a drop. If your muscles run out of energy, you're going to rigor mortis. So you will never, ever run out of energy in your muscle cells because your brain will shut you down before. That's where you hit the wall, you bonk. And that's why an athlete who's running in ketosis has a more endless supply for endurance than someone whose glucose, and they're out of glucose, their insulin's high, and they can't get the fat out of their fat cells. So now they've got to squeeze these gels in, and eventually they still can't match that. I mean, that's a different story for endurance. And all these high-carb athletes, I heard somebody, in fact, I keep referencing, but Tim Noakes was talking about, you get, this Tour de France guy who's running on high carbohydrates, he just won the yellow jacket. But the next stage up the mountains, he's back of the pack because it ain't working so good, but the newspapers will never report that. They'll report the fact that the high carbohydrate diet got him to race really well, but they won't report the fact that he's now, there's a name, it just happened now with one of the guys, big, he's high carbs, and then he doesn't finish some of the races, or he finishes back of the pack for some of the races. So I digressed a little bit, but the point is that every human being needs to understand dynamically where they are between energy provision, nutrient provision, and utilization. And homeostasis is the equal feedback. So let's say you're in a homeostatic thing and now you get COVID or you get a sickness. Now your utilization goes up or you have a surgery. We've got to accommodate for all of those things. And the beauty is to be dynamic rather than fixed in our diet. So what I like is a rigid boundary with latitude in the diet. Now, one of the other ways to fix carbohydrate or insulin suppression, and I have not personally advocated for this with my patients, but there are some patients who will eat carbohydrates every third or fourth day so that they have that little insulin bump, they keep their GLP-1 up. It's a bit like giving yourself a GLP-1 injection on a Monday. So you've got a high bolus and then it wears off toward the end of the week. Or you give yourself your testosterone, your exogenous testosterone wears off. So a similar practice has been advocated for maybe a bolus, let's say Monday, Thursday, Sunday, or something like that. I have not tried that technique. I've done more a daily provision and maybe before exercise using a little bit. You don't want to use a lot, but a little bit, which is from the Prince paper. So I've looked at some of the evidence and I've experimented a little bit with our patients and we're still working it out. But I think the key thing, Ken, is that number one, the carnivore diet is by far, in my opinion, the best way to and most rapid way to resolve metabolic dysfunction. No question in my mind about that. If you can tolerate it, the only barrier to carnivore is your humanistic tolerance for it, because it's a tough diet for some people to stick to. The second thing, though, is once you've corrected, you need to monitor your numbers and be aware that you may have to pivot or modify slightly. When you've done the correction phase or the therapeutic phase, there's an inflection point where you now go into the preventive phase. And the preventive phase affords a little bit more latitude than the strict elimination that requires therapy, that produces the therapeutic approach. And if you're going to live, let's say you correct your diabetes, you're 60 years old, you correct your diabetes in 2 years, you're going to drop at 100, that's 38 years. You're going to keep doing the same thing for that length of time. And I don't want you falling off the wagon or abandoning it because you feel like crap. I don't want you to do the Saladino. I want to modify things up front based on monitored blood work so that we make little tiny tortoise-like incremental changes to give you the latitude, keep the boundaries there, and that for me is the PhD.
So do you think that everybody on a ketovore diet or a carnivore diet, even if they feel great, should they get their labs checked routinely?
Oh, no question. No question. First of all, there's several reasons. Number one, if you do get your labs checked once a year, every 6 months, the period of time, it keeps that in your head. So a lot of people will not see a doctor for a long time. And then they feel like crap, but the sun was shining from the left side, not the right side, or, I stubbed my toe. They rationalize it away, and then they're sitting in the ER having had a heart attack. If you get your lab work done on a fairly regular basis and you feel off, you're far more likely to get lab work done early than how the hell did I do this? And there's a fear about getting the lab work done. So just the regularity keeps it fresh, just like checking your blood pressure. You should check your blood pressure regularly, even if it's normal, to keep the habit, because one day it may not be. And you want the early warning. You don't want the ER doc telling you how fast, how high it was. Secondly, if your lab work is good, there's no better high, there's no better return on the investment. Because let's say you're not diabetic and you're 6 foot tall and you've been 165 pounds for the last 5 years. There is no metric of reward from your day-to-day life. And when your day-to-day life is not rewarding you with tangible metrics, that's the prevention phase that is the longitudinal phase. Therapeutically, every day you're losing a pound, every day your blood sugar is coming down, there's an instant reward. So the value of blood work on a fairly regular basis is that psychologic tangible reward that it's paying off. It's confidence, especially, Ken, and you know this, in a world where everybody's telling you what you're doing is wrong. And my blood work is my proof that I'm okay. And I can use that as a badge of honor, my blood pressure, like this morning, was 110/65. I walk out of that house on a high because I'm proud of what I'm doing. But It also, if anything then changes, you've got not just a set of blood work that may or may not be off. You've got a metric of comparison. So I can look at you today and look at you 3 months ago, 6 months ago, and say, hey, these numbers are starting to go off. And if it happens twice, this is not sudden stuff, but if it's a trend, we can adjust and be ahead of the trend before you're fatigued, you can't sleep, your muscles are wasting, but you're exercising, your testosterone's in the toilet, your libido's in the toilet, your hair's falling out. Does that make sense?
I hear what you're saying. Dr. Cywes, I appreciate you taking the time to do this with me. I love hearing your thought processes. This is a lot to process for a lot of people, and I hope that we get a lot of comments on this video and a lot of questions. Where can people find you if they want to follow you further?
Well, first of all, Ken, your philosophy and approach to the topic of blood work, this book, this thing that is coming out, I think on the 26th of August, I wrote something here, and it says that Ken emphasizes clear, common sense explanations that empower his patients not just to diagnose, but to be able to have meaningful, smart conversations with other like-minded people, be they clinicians or other. and it encourages active patient advocacy for themselves. So what you're doing is not just providing us a reference book, you're providing us advocacy and knowledge and approach to managing the healthcare system. So kudos to you. You know, I'm not blowing smoke up your skirt because it's just not what we do, but I'm really, really thankful for this. So that's the first thing. What I'm able to do, and this is where you and I wear slightly different hats, I'm a clinical physician. I see patients every single day. I see tens of thousands of blood work because I'm very blood work centered for that monitoring and the management. That's why patients come to me. If you're interested in starting, if you're unsure about where you may be, if you want those blood work reads, if you want that adaptation, I'm a clinically practicing metabolic specialist. We have a single phone number. We can use WhatsApp, we can text, we can call, you can leave messages to enter our practice. It's +1 if you WhatsApp, 561-517-0642. And that number, it doesn't get answered right away. It'll get answered in the day, but you will get a response. They'll set up a visit. The first thing I will do when I see my patients is I will get to know you as an individual entity by looking at your family history, by looking at where you are, where you've come from, and what you're doing, so that I know where you are. I'll then design blood work, usually get a CAC score because it hasn't been done. Look at the various parameters that you're looking at, get blood work, get that testing done, then didactically interpret the blood work and suggest little tweaks to stay ahead of overcorrection.
Excellent. So just call that number and you can get in touch with Dr. Cywes if you need that extra help. And we'll put that phone number down in the show notes. Thank you so much, Dr. Cywes.
Can I just say one other thing,
Yes.
Ken? Behind you is something that I took when I came out of medical school. You've got Hippocrates behind you.
Yes.
And the most important thing is do no harm.
Absolutely. You should hear Abby Grace, or Bonnie Blue, who just turned 3 years old. She'll say, "Is that Hippocrates?" And I'll say, "Yes, it is, honey. That's a meat-eating baby for you right there."
I love that.
She knows who Hippocrates is, and you and I both took the oath, and you and I both meant it when we took it, and that will give you my lifelong respect. And I love your intellect, and I love that you're always thinking about things and questioning things. You and I don't always agree, but that's good. That's actually a benefit to people because they can do what I say for a while. If it's not working, do what Cywes says for a while. If it's not working, try something else for a while. And we're all in this together. We all got this one life, and we're all trying to rediscover a proper human diet together as a tribe. And I love that. Thank you so much, Doc.
Thank you very much, Ken. It's a pleasure, as always.
Bye-bye.
Bye-bye.